Uh, in this lecture, we are going to discuss jaundice, or sometimes it's called icterus, which is yellowish discoloration of the skin and uh, sclera, as we will see. As a rapid revision for the anatomy, we know all that the biliary system started in the liver from the right and the left hepatic ducts that join together, forming the common hepatic duct. And this, together with the cystic duct coming from the gallbladder, form the common bile duct. And the common bile duct, as we know, um, usually join with the pancreatic duct, okay, uh, and open in the duodenal papilla. The joining is called the ampulla of Vater, and the bulge is called the duodenal papilla. And this is surrounded by a sphincter called the sphincter of Oddi. Regarding physiology, we have the bile, which is formed in the liver. Bile salts formed in the liver. Bile pigment usually formed in the spleen. How? From the senescent or effete RBCs, it will be damaged by the spleen, producing heme and uh, globin. The heme will be converted by heme oxygenase into biliverdin, which has green color. And then this green biliverdin will be converted into bilirubin, which has yellow color by biliverdin reductase. And then to be secreted into the bile as bilirubin, it needs to be conjugated into bilirubin mono and diglucuronide by uridine diphosphate glucuronide transferase enzyme inside the liver. So the liver has to uptake the bilirubin from the blood. At that time, it is unconjugated. Then, by a process of conjugation, it will be converted into direct or conjugated bilirubin. The difference between unconjugated or indirect bilirubin and conjugated or direct bilirubin is that the unconjugated bilirubin is water insoluble, so it will not be secreted by the kidney, while conjugated bilirubin can do this way. Yani, if the conjugated bilirubin is elevated, it can go to the kidney and be secreted, so the urine at that time will be dark. While unconjugated bilirubin is fat soluble, so it can go to the through the blood-brain barrier to the brain, causing sometimes in pediatric age what we call bilirubin encephalopathy or kernicterus. While conjugated bilirubin is fat insoluble, so it will not go to the brain, and no hazard or no risk to cause kernicterus by elevated conjugated bilirubin. Bile acids are formed in the liver from cholesterol. We have initially primary bile acids, cholic acid, and phenodeoxycholic acid. And then, following their synthesis, they are conjugated in the hepatocyte with glycine or taurine, causing conjugated bile acids or bile salts. The primary bile acid will be converted by the colonic bacteria or microbiota um, into secondary bile acids. And cholic acid will be converted to deoxycholic acid, while phenodeoxycholic acid will be converted into lysocholic acid. And then we have what we call enterohepatic circulation, so that the bile salts will be back again to the liver, enterohepatic, which occurs from 2 to 15 times per day. So this is just a brief introduction of what have been studied before. Now, what is jaundice? Jaundice is yellowish discoloration of the skin and mucous membranes, including the sclera. Why? Due to accumulation of excess bilirubin, which has yellow color. So this is called hyperbilirubin. The normal serum bilirubin usually up to 1 milligram per day, maximum 1.2. Usually the clinical presentation of jaundice with peripheral yellowing of the sclera of the eye, or called what we call scleral extras, usually occurs when the bilirubin exceeds 2 or 3 milligram per day. Even in the skin, it needs to be high to the level of 6 milligram per dl to appear in the skin, starting by the skin of the face. So what are the causes of jaundice? Jaundice uh, is classified into three types: pre-hepatic, hepatic, and post-hepatic. Pre-hepatic, during the process of destruction of hemoglobin to yield or to produce bilirubin. Hepatic, during the process of conjugation and the secretion of the bile through the bile canaliculi. Cholestatic can occur due to problem in the canaliculi, or it can occur extrahepatic in the bile ducts, common bile duct. So we have prehepatic. Usually this will occur due to increased bilirubin load due to hemolysis. And then we have hepatic, which may be due to decreased conjugation, as in Gilbert and the Krigler-Najjar, may be decreased uptake in hepatitis and sometimes inherited, and may be due to decreased canalicular secretion, what we call cholestatic hepatitis, maybe also with some drugs, sex hormones, and sometimes inherited. Cholestatic also can be at ductular level inside the liver, what we call primary biliary cholangitis, primary sclerosing cholangitis, and IgG4 cholangitis. Or it may be due to bile duct obstruction, which may be calcular, as in gallstone, or malignant, as in cancer head of the pancreas or cancer of the bile duct. So these are the causes of jaundice. This is a prehepatic, as we said, may be due to increased load of bilirubin arriving at the liver, as in hemolysis, or diminished hepatic capacity for conjugation of bilirubin, as in Gilbert and Krigler-Najjar syndrome, as we will discuss. In these situations, the circulating bilirubin is predominantly unconjugated. So we can call this also as predominantly conjugated, predominantly conjugated, predominantly unconjugated hyperbilirubin. In these situations, usually the transaminases and the alkaline phosphatase, all liver enzymes are all normal. And we know that unconjugated bilirubin, as we said, is cannot be excreted in the urine. It is water insoluble. Why? Because it is firmly bound to albumin in the circulation. What about the hepatic? Hepatocyte damage results in reduced efficiency of bilirubin excretion into the bile. Reduced efficiency of bilirubin excretion into the bile. And conjugation is often preserved. And because conjugated bilirubin is water soluble and it will reflux into the circulation and increase, this can be executed in the urine, causing dark urine. And also, because it is hepatic, usually the transaminases will be high according to the cause. For example, if it is hepatitis, will have transaminase high. If it is cholestatic, alkaline phosphatase will be high, like this. Post-hepatic or cholestatic, this is due to failure of adequate amount of bile to reach the duodenum. No bile reaching the duodenum in adequate amount. So what will be high? Conjugated bilirubin, alkaline phosphatase, gamma GT, total cholesterol, conjugated bile salts. All things responsible for the bile. At one part, the bilirubin, conjugated bilirubin will be high and deliver enzymes. And in another part, the bile salt metabolism, so total cholesterol and the conjugated bile salt will be high. And lack of bile salts in the bile may cause, if no bile salt reaching the duodenum, so no fat digestion, so it will cause steatorrhea and malabsorption of calcium and the fat soluble vitamin A, D, E, K. Adi. Now, short note on some of the causes. Uh, hem- Hemolysis. We know that the liver has a considerable capacity to conjugate and secrete bilirubin. However, serum bilirubin levels increases when there is increased hemolysis or breakdown of heme, which may be acute, as in transfusion of incompatible blood, or chronic, as in hemoglobinopathies like sickle cell anemia and thalassemia. So there is increased amount of heme, and in turn increase the amount of bilirubin out of the capacity of the liver to be secreted. So in such cases, what will be increased? Unconjugated bilirubin. So bilirubin in the urine, no increase unconjugated bilirubin in urine. So the urine is still in its color. So what we call aqueous joint. But in the stool, there will be some bile, so it may be dark. And also due to hemolysis, we can have reticulocytosis, decreased haptoglobin, increased indirect or unconjugated bilirubin, and lactic dehydrogenase. This is the enzyme that will be high in case of hemolysis. Next is Gilbert, and it is caused by reduced activity of bilirubin conjugating enzyme, UGT. The bilirubin conjugating enzyme has reduced activity. Okay, so due to gene mutation in the UGT1A1 gene. The gene variant is very common. It is in 16% of the population, but Gilbert syndrome, which is autosomal recessive disease, occurs only and present with clinical jaundice only when both alleles from mother and the father are affected. And this genotype usually present in about 6% of the population. Usually, no symptoms in Gilbert, just maybe fatigue or mild jaundice. But the notable thing is that after fasting, if the patient with Gilbert fast, serum bilirubin will be increased by about half milligram per dl. Next is Crigler-Najjar. In Crigler-Najjar syndrome, this is the most severe bilirubin conjugation defect. The most severe bilirubin conjugation defect. And it is caused also by structural mutations in the coding region of the same gene, UGT1A1 gene. And the patients with Crigler-Najjar have very high serum levels in direct unconjugated bilirubin. And it is of two types, phenobarbital responsive and phenobarbital unresponsive. Usually, these diseases are seen in pediatric age because it manifests itself after birth by prolonged neonatal jaundice. And the main risk of Crigler-Najjar, because there are very high serum levels of indirect or unconjugated bilirubin, which is fat soluble, that it can pass through the blood-brain barrier, causing bilirubin encephalopathy or kernicterus. Then disorders of uptake, including hepatitis, viral hepatitis, drug-induced hepatitis, alcoholic hepatitis, or it may be inherited, as in Rotor syndrome, which is a rare autosomal recessive disorder, and it is clinically detected by mild jaundice caused by elevation of both conjugated and unconjugated bilirubin. Usually, it is only a laboratory find, only a laboratory find, and the liver is normal. Liver histology and liver enzymes even are normal. This is in rotor. But we have one more serious disease, which is a disorder of hepatic secretion, which may be cholestatic hepatitis, drug also, sex hormones, and inherited, as in Dobbin-Johnson syndrome, which is relatively rare autosomal recessive disorder and characterized by mild elevation of conjugated bilirubin, again without liver enzyme abnormality. And it doesn't cause symptoms and it doesn't give rise to liver disease. The difference from rotor is that the liver histology is dark, black-brown lysosomal pigment due to condensation of epinephrine metabolites. So this is the difference in double, remember, double dark liver. The liver histology has black-brown pigment. Okay, now what is the approach to a case of jaundice? We have items in the history, in the examination, and investigation. In the history, we have to ask about the onset. Cholestatic jaundice may develop slowly and it may be preceded by itching or pruritus for a couple of months or years even. Yani the patient will start by itching, will visit many dermatologists, no diagnosis, then jaundice will appear. This is the usual scenario. Typical in primary biliary cholangitis. If the patient has gallstone and this one of them went into the common bile duct, at calcular cholecystitis or gallstone can present with biliary colic, which is episodic, acute, persisting for several hours, epigastric or right upper quadrant, and radiating to the right shoulder, and may be associated with dyspepsia and intolerance of dietary channel. Sometimes the onset of jaundice may be associated with fever with rigor. In this case, suspect cholangitis due to gallstone or biliary extraction. Because cholangitis has what we call charcot-triad. Charcot-triad is pain, fever with rigor, and jaundice. In the history also, we have to ask about age and the sex, because hers middle-aged obese female are typical patients for gallstone. Female, fatty, 40 or 50, fertile. This is the usual patient for gallstone. Although it is not always like that. Maybe in male, maybe in non-obese, maybe in young or elder, maybe also in non-liberals. But this is the usual. Also, Age is very important because an elderly man who presents with jaundice, we have to think about malignant obstruction, like cancer head of pancreas. Drug jaundice also in adults and old age, very rare in children. But hepatitis A usually in young age, and the incidence decreases as age advances. While hepatitis B and C, B with or without B and C can occur in age. Also ask about association. Yani, if the patient told you that he has ulcerative colitis and he is presenting now with jaundice, you have to think about primary sclerosing cholangitis. If the patient told you that he have just done biliary tract surgery and then presented with jaundice, think about residual stone or injury to the bile duct or during anesthesia drug-induced hepatitis. If the patient told you that there is severe epigastric or epigastric pain, central pain, radiating to the back, and the patient is leaning forward, this is typical of cancer head of pancreas, pancreatic carcinoma. If the patient complains of weight loss, which is progressive, think about pancreatic carcinoma or severe chronic pancreatitis due to malabsorption. If the patient has prior history of malignancy, like cancer, breast, or whatever, think and there is now present with jaundice, think about liver metastasis. No. If the patient is seriously ill, critically ill in ICU and presented with jaundice, think about sepsis or septic shock or drugs. If the patient presented with nausea, anorexia, and stays to smoking, think about viral hepatitis. So associations are very important. Also, in patients with jaundice, don't forget to ask about drug history. So, for example, treatment with cotrimoxazole or amoxiclav may precede the onset of jaundice by several weeks. Also, cholestatic jaundice may persist for many months following adverse reactions to certain drugs like erythromycin, flucloxacin, flucloxacillin, and chlorpromazine. All these can cause jaundice, drug-induced jaundice. Also, ask about risk factors like contact with jaundiced person, close contact with patients on renal units, or contact with drug abusers, or any injection in the preceding 6 months. Think about viral hepatitis. Positive family history might be a clue to the diagnosis of hemolytic jaundice, congenital hyperbilirubinemia, and hepatitis. Contact with rat, excreta, infested water. Think about leptospirosis or viral disease. Now, what are the points in the physical examination to ask about or to look for? Look for first the depth of jaundice. The depth of jaundice, it might be yellow like a lemon in hemolytic jaundice, or orange color, yani yellow like orange in hepatocellular, or deep green if prolonged biliary obstruction. Why green? Because of biliverdin increase. What if the patient with jaundice, you look for pallor, and you found anemia. It may be due to hemolysis, may be due to cancer, may be due to cirrhosis. What if the patient complained of weight loss? By examination, patient was again. Think about cancer and the severe malabsorption as in chronic pancreatitis. Decubitus, as we discussed, a stooped up position suggests pancreatic cancer. The patient will be stooping up, leaning forward. If you are suspecting liver metastasis, you have to examine the breast, thyroid, lung for primary tumor. And also you have to examine for the lymphadenopathy, like enlarged left supraclavicular lymph node, what we call Virchow lymph node, which occur in cancer stomach. Also in jaundice, you have to examine the mental status, because slight intellectual deterioration and the minimal personality change can occur due to hepatic encephalopathy and suggest hepatocellular jaundice. Also, fetor hepaticus and the flapping tremor indicate that. Also, don't forget to look for the skin. Scratch marks due to pruritus. Melanin pigmentation. Finger clapping, lapping tremor. Xanthoma of the eyelid, and xanthoma in the what we call xanthelasma, or in the extensor surfaces and the palmar creases. You have to look for. This is caused by what? The marked increase of cholesterol on chronic base. And if there is chronic cholestasis. Also in the skin, look for bleeding tendency, bruises. This may indicate clotting defect. Purpuric spots. Also, you have to look for berbera, may indicate thrombocytopenia due to cirrhosis. And also look for other cutaneous manifestations of cirrhosis, like spider nevi, vascular spider, like palmar erythema, like white nail or leukemia due to hypoalbuminemia, and the loss of secondary sexual hair. Again, pigmentation of the shin and ulcers may be seen also in some hemolytic jaundice. Big ulcer is an important sign in those with congenital hemolytic anemia. Also, multiple venous thrombosis suggest carcinoma of the body of the pancreas. And you have to look also for ankle edema, which may indicate cirrhosis or obstruction of the inferior vena cava due to thrombosis or hepatic or pancreatic malignancy. So edema is also important. All these are general. Local abdominal examination, look for the liver. If the liver is very large nodular liver, think about cancer, hepatocarcinoma. If it is a small, shrunken, think about cirrhosis. If it is enlarged but smooth, not nodular, think about extrahepatic cholestasis. If it is tender, think about hepatitis, congestion, alcoholism, and bacterial cholangitis. All these can cause tender liver with jaundice. Also, gallbladder. Gallbladder examination is very important. In gallstone, the gallbladder area may be tender, and the Murphy sign will be positive. You will put your hand here, the thumb of your left hand, or the fingers of your right hand in the gallbladder area, and you will ask the patient to breathe in, then inspiratory arrest will occur if there is cholecystitis, acute cholecystitis. Why? because when the patient take breath, the gallbladder will go down and touch your finger. So the patient will feel tender pain, and this is called nerve sign. But imagine if the patient has carcinoma of the pancreas. What will happen? The gallbladder is at that time healthy. Look here in the anatomy. Sorry, we'll be back to the anatomy here. If we have here cancer head of the pancreas, this is the area of the pancreas. Okay, cancer head of pancreas here. It will press only common bile duct. Bile will not be able to go down, so it will be backflow because the gallbladder at that time is healthy and distensible. It will be enlarged. This is called Courvoisier sign. This is called Courvoisier sign. Okay. Also look for the spleen, splenomegaly. You have to think about hemolytic jaundice, infiltrations like Hodgkin, or cirrhosis due to portal hypertension. Also in the abdomen, we have to look for ascites, which may indicate cirrhosis or maybe malignant ascites. Also look for an abdominal mass, which may indicate the primary tumor. Maybe mass in the colon, mass in the stomach, mass in the pancreas. Have to look for it. Finally, what about lab investigation? We will start by lab, of course. What we will ask for, serum bilirubin confirms jump, of course, indicates the depth, and used it to follow the progress. Also look for the enzymes. Alkaline phosphatase, if it is elevated more than 3 times the upper limit of normal, this suggests cholestasis, particularly if there is no bone disease and it is associated with elevated gamma GT. But in hepatocellular jaundice, you will find features of cirrhosis. Albumin will be decreased. Globulin will be elevated. Transaminases will be high. Maybe slight elevation of alkaline phosphatase. And CBC, iron deficiency anemia, in a patient presenting with obstructive jaundice may indicate bleeding from the carcinoma of the ampulla of Vater, or anemia due to hemolysis. Hemolytic anemia can also occur. What if there is leukocytosis in the CBC? Think about acute cholangitis. Think about underlying malignant disease. Think about alcoholic hepatitis. In viral, expect leukopenia. In alcoholic, expect leukocytosis. What also if prothrombin time and IMR is prolonged? Think about either cholestasis, because as we said, cholestasis will affect the fat-soluble vitamins, including vitamin K. So the vitamin K dependent clotting factors will not be formed, so there will be coagulopathy in cholestasis. But also, if the jaundice is hepatocellular, the liver is affected. So all clotting factors are affected because all clotting factors are formed in the liver except von Willebrand, which is formed by megakaryocyte and vascular endothelium. Only von Willebrand. All other clotting factors are formed in the liver. So, in these two conditions, INR prothrombin time will be prolonged. So, how I can differentiate? In cholestasis, the liver is okay. The problem is only in vitamin K. So, if I give the patient vitamin K, 1 parenteral, 10 milligram, within few hours, the bilirubin, the prothrombin time will be correct. The INR will be correct. While if it is due to damage in the liver itself, hepatocellular jaundice, exhibit because the factory is damaged, clotting factor synthesis will be affected. So expect little response. As we said, if hemolysis is suspected, investigation should include reticulocytic count, as we said before, examination of the blood film. If marked brisk intravascular hemolysis will be verified by hemoglobinuria and the fragmented RBCs on blood film, which can occur in Wilson disease and may be caused also by hepatitis A in patients with G6PD deficiency or by parvovirus infection in hereditary spherocytosis. Now, what about radiology? Very important ultrasound. It can diagnose cirrhosis. It can look for the dilated common bile duct in obstructive jaundice. Occasionally can see the mass in the pancreas. May see common bile duct stone. Also, ultrasonography and at the same time fibroscan, both are important in diagnosing cirrhosis. In fibroscan or transient elastography, we measure what we call liver stiffness. Depending on its value, we can diagnose or rule out cirrhosis. Then the next further step, sometimes we might need MRI, MRCB. MRCB, magnetic resonance. Yeah, it is MRI, but for what? For CT. Cholangio, I mean the bile ducts. Pancreatography, I mean the bile ducts. So MRCB, it can visualize the bile ducts and the pancreatic duct. Also, CT scan may be important, especially in case of mass lesion. If you are suspecting primary sclerosing cholangitis, MRCB can be used. Before MRCB, we were doing ERCB as a diagnostic, but now endoscopic retrograde cholangiopancreatitis, because it is invasive, because it is endoscopic, it is usually used on therapeutic background. Also, dynamic four-phase MRI and the CT scan are typically used to diagnose hepatocellular carcinoma, and they, to a great extent, replace the liver biopsy. Yani, of little use, liver secretion function tests by technetium 99 nephrophenine or HIDA scintigraphy or PET scan positron emission tomography. They are not often used in clinical because expensive. They are expensive. Finally, liver biopsy. When if you are suspecting intrahepatic cholestasis and you will not able to diagnose the exact cause. If intrahepatic cholestasis from clinical data and scanning is suspected, then liver biopsy may solve the issue. But don't forget that those patients are liable to bleeding because of the vitamin K affection. So correct prosthromboid time first. And also you need to have the INR less than 1.5. The normal is 1. Also, you need to have the platelet count above 50,000. The normal is 150 to 400. Thank you.